الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. My dear friends and students, now this is a tutorial of about for the final year MBBS primarily, but PG can be benefited if they want to listen this tutorial. It is the topic is something about the acute severe chest pain with breathlessness. So there are a wide differential diagnosis. So I am actually the facilitator, Professor Sayyid Ali Haider. I am representing as a visiting professor of medicine at the Jinn Sindh Medical University. Scenario: a 63-year-old woman with a stage 4 lymphoma calls the ambulance for the acute shortness of the breath. At baseline, the patient is mobile and does not have the shortness of breath. She is also taking hormone replacement therapy, HRT. Mainly the components of the HRT are the estrogen derivatives. On the day of the admission, she develops a sudden shortness of the breath and a new pleuritic chest pain. She does not improve with the nebulizer treatment on the way to the hospital. In the ER, her pulse was 115 per minute. Respiratory rate was 36 per minute is tachypnea, and it is sinus tachycardia with a temperature of 100.1. So she has had the feverish feeling also, and the oxygen saturation was 88%. It is lower down at the room air. It should be more than 90%. On examination, her lungs are clear and her extremities are normal. A chest X-ray showed the mid right-sided atelectasis, and EBG shows pH 7.48. 7.35 is the limit. So it is higher, it means it is alkalosis, it is probably the respiratory region. The limit is the respiratory alkalosis, pH2 is 32, lower down, confirming that the carbonic acid is not found in the blood because it is expired because of the tachypnea. And the bicarbonate concentration, serum bicarbonate shows the 18 mg equivalent, which is lower down. It should be 22. So it should be compensated by this. It is not compensated yet. Uncompensated respiratory alkalosis. And PO2 was measured at 50 millimeter of mercury in the room air. It is lesser. It should be 60 to 70%. Questions are the same, 4 parts. What is the differential diagnosis? How will you further investigate this case? What is the most likely diagnosis and justify your diagnosis? And what should be the lines of the management? The most likely diagnosis in this condition, other than differential, it may be only differential. For example, acute coronary syndrome, pneumothorax, massive pleural effusion, and along with it, the acute pulmonary or pulmonary edema or acute pulmonary embolism. So, maybe possibility of anything, but the history and the examination revealed that it is very near to the acute pulmonary embolism. So, we are discussing actually the pulmonary thromboembolism. The incidence is unknown actually in the world is concerned, and is suspected to be underestimated because many of the hospitals in the world do have their records. But in third world countries, they they have no records for this type of a problem. It is estimated it will be between 0.5% roughly to 3% in the general population. It is just assumption. Mortality from the pulmonary embolism is estimated to be 0.1%. 1 in 1,000. Not bad. Mortality is good nowadays. Now, before 20 years back or 30 years back, it was 10%. Now it is 0.1%. My own father died because of this problem in 1973, because of the pulmonary embolism. So what are the risk factors associated? Are the previous or the current deep venous thrombosis, immobilization, surgery within the last 3 months, stroke, paralysis, central venous instrumentation within the last 3 months. It may be malignancy which was diagnosed, and congestive heart failure which slows the circulation, autoimmune diseases cause vasculitis and can cause the formation of the thrombus. Air travel can cause it because of the pathogenesis is that because of the pressure difference in the lower down and upper down. Those people who are prone to develop and they are sitting in the 6 hours to 8 hours in one seat, both factors will operate here and can cause the embolism through venous stasis in the lower limbs. Thrombophilias, where the all coagulopathies are describing here. There are different types of coagulopathies, you know that. One coagulopathy which is important is that there is balance should be between the clotting factors and the bleeding factors in the blood. So naturally occurring anticoagulant, name them. Now they are protein C, protein S, and antithrombin 3. These are the naturally occurring anticoagulants. Coagulants are manifold in the cascade. There is a cascade of the bleeding you have already there. You have already learned in the hematology. And that's cascade. Whether the intrinsic pathways was there, extrinsic pathways were there are many factors operating, 1, 2, 3. And then the fibrin clot is formed. You know that about it. So balance should be there between the bleeding factors and the clotting factors. In the studies, they said there is deficiency which is associated with the protein C in the formation of the mutation which occurs, and it will not work. And the factor which derives from it is called factor 5 leadine, and there is some person in factor 2 leadine is there. Because of the formation of these factors, the person prone to develop and tends to develop the thrombophilia or formation of the thrombus in the body. Now specifically speaking of the women, if the BMI is more than 29, means overweight or obesity, chances of the embolism are more. Pregnancy again is a risk factor, many factors operating behind it. Heavy cigarette smoking, they said more than 25 cigarettes per day for more than 25 to 30 years may be the risk factor for the formation of the thrombosis in the periphery. For example, peripheral vascular diseases, for example, the Berger disease is related with the smoking. And hypertension itself is where the atherosclerosis process is going on, and the thrombus will form in the peripheral vasculature. So these are some discussion, about how are the risk factors they are behind the scene. Every scenario should have one of this problem behind it. Who has the attack of the pulmonary embolism? Presentation is that the dyspnea at rest with exertion 73%, pleuritic pain is 44%, cough 34%, using of the more than 2 pro because of the orthopnea 28%, cough or thigh pain 44%, cough or thigh swelling 41%, wheezing was noted in 21%, and rapid onset of dyspnea within seconds 46%. As seen in my father, he was all right, and he was talking to me when he said that I am, short of breath, and he died after 2 hours after this event. Within minutes, 26%. Most common signs are tachypnea, tachycardia, rales, decreased breath sounds, where the thrombus lodge and prevent the entry of the blood into the lung parenchyma. Accentuated pulmonic component of the second ultrasound means that back pressure will cause it. And the jugular venous distension can be observed because of the right atrium in under pressure, or on the right side, not on the left side. Ultimately, the left side of the heart will be involved if you delay management. Now, clinical decision rules are that the model for assessing the clinical probability of the pulmonary embolism. Wells score or Geneva score. Score the patient for the risk and for the mortality. Wells score is that the clinical symptom of the DVT, like swelling, pain with palpation, if you palpate it. 3, score 3. Other diagnosis is less likely than pulmonary embolism. 3 means that there is no finding in this examination. It is the dislodgement of the thrombus and causing the pulmonary embolism directly. 3, heart rate, tachycardia 1.5, embolization of more than 3 days, continuous immobilization, or surgery in the previous 4 weeks 1.5. That is why they ambulate the patient just after surgery or after 1 day. So immobilization should not be done. Patient should be encouraged. Either or secondly, you can do the physiotherapy. The previous DVT, history of the DVT or the pulmonary embolism 1.5, hemoptysis associated is 1, malignancy 1. Now this is the scoring system, clinical symptomatologically. The traditional clinical probability assessment is, if you add this thing, if it is more than 6, it is high. If moderate is between 2 to 6 and low less than 2. Simplified, if it is simplified by probability assessment, then the pulmonary embolism is likely if the score is more than 4. Likely, not confirmed. Pulmonary embolism less likely or least likely is the score is less than 4. This is a simplified revised Geneva score. They are actually following it on the other countries. Age is more than 65, 1. Previous history of the pulmonary embolism, DVT, 1 score. Surgery of the fracture within 1 month, 1 score. Active malignancy, 1. Unilateral leg pain, 1. Hemoptysis, 1. Heart rate 75 to 94, 1. More than 95, 2. Pain on the lower limb, deep venous palpation, and unilateral edema, 1. Clinical probability, low 0 to 1. Intermediate is 2 to 4 scoring, and high is more than 5. And second one is levels Wells score. Clinical signs and symptoms of DVT 3, immobilization or surgery in the previous 4 weeks 1.5, heart rate greater than 100 beats per minute, previous history of the pulmonary embolism or DVT 1.5, hemoptysis 1, malignancy 1. Now, all scoring system cannot be remembered. Bell's score can be remembered if you learn by 2 to 3 times. Many of the points can be covered. So only one scoring system can be taken at the bedside. Diagnostics tests. First of all, starting with the D dimer, and elevated in the thrombosis, malignancy, pregnancy, elderly hospitalized patients. And in cases of the disseminated intravascular coagulation, you do the D dimer. What you do is called D dimer. It got a very important diagnostic tool. A role in the low moderate probability of the pulmonary embolism. Normal result can rule out pulmonary embolism. Normal result, if they are absolutely normal, lower, it means that it is not pulmonary embolism. Estimated 3-month risk of thromboembolism with negative D dimer is 0.14%. Very least chances. Role in the high probability patients leading to proceed to the CT, negative D dimer can miss up to 15% of the patient in this group. There are the two parts, remember. One is called sensitivity, second is called specificity. Specificity is good, no doubt. Sensitivity is a problem. It is about, you can say, 80 to 85% sensitivity in this case, and it is specificity is more than 95%. Now, electrocardiogram is concerned, now it's specific, it is non-specific. Most commonly, sinus tachycardia with the possible non-specific STT wave changes, which you see also in cases of the non-STMI. Only 10% of the patient can have what we actually, on the bedside, they said, remember S1, QT, T3. S1 is lead 1. Prominent S wave in lead 1, dim leads. And Q wave prominency in lead 3. S wave in lead 1 or 2. S1, Q3, and the T negative downgoing in lead 3 limb. It is lead 1 S1, Q3, non-significant Q wave, and T wave inversion in third lead. Not reliable. Non-specific ECG changes can be there. Other EKG abnormalities including the atrial arrhythmia, the right bundle, RBB, inferior Q waves, and precordial chest leads, T wave inversions, and ST segment changes are associated with the poor prognosis. Now, this will come in the mortality. It will increase mortality if you see these things. Otherwise, it is not diagnostic. Very least sensitive index of the pulmonary embolism, electrocardiography. Chest radiography, plain, not a sensitive or specific test for the diagnosis of pulmonary embolism. One cannot read the normal X-ray, my dear. In most of the cases, you don't know how to read the X-ray properly. You are dependent on the radiologist. Atrial excessive pleural effusion or pulmonary parenchymal abnormality is noted most commonly, because if the blood is not going to the specific parenchyma, lung parenchyma, it means that the blood is not going, it means the air shadowings are more at that area. And distal to it, there is engorgement because of it is blocked, and it is not supplying the specific part of the lung segment or whatever it is, it will be collapsed. Atelectasis can be seen. And only a small portion of the patient with the pulmonary embolism have a normal chest X-ray. Very sensitive eyes can pick the chest radiography, very sensitive eyes. If you have got the sensitive eye, you can pick. Here you see there, this is shown here. Now see here, in this case, there is hyperturbulence, where the proximally you see the congregation of the haziness here, rather, I will say. It should go up like this, like this. It is not going up like this. This is a very nodular type of obesity is seen here, because the blood supply is cut down before it. Distally there is hypertension, and proximally there will be haziness. This is known as the Worcester mark sign. It is difficult to diagnose, not easy one. Although here other changes are seen, upper lobe divergent, and the more bronchovascular markings are there on the left side, and again here on the lower side. And there is slightly haziness also seen here. But this is the part where the eyes, if they are sensitive, they can pick. And the second one is what is called is the Hampton's hump. The clear kit opacity you see here, homogeneous type of the opacity, where the blood collects because of the blockage of the pulmonary artery. The other areas are hypertransulent around it. Is a conical projections coming out. It is called the Hampton's hump. It may be on the lower lobe, it may be on the middle lobe, and it only indicates the differential diagnosis. It may be a pneumonia, it may be a mesothelioma, it may be chronic inflammation, it may be anything. The thing is, this part, which is seen here, it is the part which is very, very, very linear part is seen here. This is the transfer fissures. Now it is lower down. It means the collapse occurs in the adjacent area. It is the direct sign of the atelectasis. At one time, the ventilation perfusion scans was done. Useful if normal negative predictive value is 97%. To exclude it, exclusion criteria. It is also useful in the high probability positive predictive value of 85 to 95%. The VP scan, at one time they were doing in the tertiary care hospitals. It is difficult to do, but they were doing. Unfortunately, only diagnostic in 30 to 50% of patients, although the work is hard to do it. You go for the ventilation, you go for the perfusion, and then you match the ventilation with the perfusion and then see it, A and B. Here it is ventilation, here it is perfusion. If the mismatching occurs very clearly, it means that the scan is positive. The CT angiography nowadays is the gold standard, and it is got the high sensitivity index of 99%. 99%. Specificity is about 97%, 96 to 97%. Studies have shown sensitivity of close to 95% with an experienced observer, and one of the most commonly cited benefits of the angiography, CT, is its ability to detect alternate pulmonary abnormalities that may explain the patient's symptoms and signs. If possible, you go for the MRI, that is MRA, pulmonary angiography. That is called what is called the virtual angiography. If it is possible in these patients, it is more important. If it can be done. In 67% of patients without pulmonary embolism, CT provided additional information for alternative diagnosis. Some other things are there. Other diagnosis is there for the same symptomatology. Comorbidities, it means that can be picked by the CT, may predispose patient to further necessary testing. Unnecessary testing. Unnecessary testing. A lot of tests can be done. PTNR, APTT, the CBC for thrombocytopenia, and the many things else. The D-dimer. To avoid the unnecessary testing, this is very good diagnostic tool. This is angiogram which is seen. You see, this is thrombosis, this is thrombosis, this is thrombosis. Pulmonary thrombosis here again, and the embolism. Thromboembolism, that is, we call it the pulmonary thromboembolism. The gold standard, I say already mentioned out, is the pulmonary angiography. You inject the dye in the pulmonary artery and see the tree. Now here, this is marked here. Look at this. This is the catheter which is going on. It pushes the dye, and see the other part is not visible here. This part is not visible. The angiogram here will show you here are two embolus is lodging in this area. It is the gold standard. It can be performed. Otherwise, I say that today we go for the MR angiography. That is more sensitive. MRA, magnetic resonance pulmonary angiography, alternative to it. But again, I will say the angiography directly is the more gold standard of the world. It was asked in the examination of one of the candidates of who is appearing in the clinical, the diagnostic radiology, that which is the most sensitive index in the world. He said it is CT angiography. And the examiner said no. The gold standard is again the direct pulmonary angiography. Because a negative pulmonary angiogram excludes absolutely the pulmonary embolism. Is 100% specific and 100% sensitive. The risk of embolism in patients with a negative angiogram is extremely low. If it is negative, means in the future the probability of pulmonary embolism is very low. Diagnostic pathways is there important to use the clinical decision actually, how the patient presents, how we proceed with the patient. Going the fancy investigation will take time, and patient will die. This is the algorithm which is written here. If the pulmonary embolism is likely or pulmonary embolism is unlikely, useful algorithm. Pulmonary embolism unlikely in those cases the D-dimer assay is less than 500 nanogram and excluded. Even excluded, you can exclude if it is less than 500. If it is more than 500, it may be, or it not may be, possibility. So it will go here, the pulmonary embolism likely, the spiral CT pulmonary angiogram, CTPA that is called. If it is more than D-dimer 500, then you go for this. If it is positive, then the pulmonary embolism is confirmed in 99% of cases, 98 to 99. If it is negative, it is excluded. Easy, very easy. First go for the D-dimer. If it is more than 500, go for CT angiography. If it is positive, it is confirmed. Otherwise, it is less than 500, excluded. Lower extremities, ultrasound indicated, of course. What is the source? So you go for the ultrasonography, Doppler, color Doppler, and see whether the venous, there is evidence of the venous thrombosis is there or not. Specifically speaking, in cases of renal insufficiency where the contrast is not possible because of the renal insufficiency or allergy, and the critically ill patients who cannot bear the burden of the CT angiogram. It is an inexpensive test without radiation exposure and can avoid additional testing if possible. So if it is positive, if there are venous thrombosis in the lower limbs and the patient arrived with the severe dyspnea with chest pain, then on the basis of these findings you can diagnose the pulmonary embolism. Management is, of course, you have to resolute it other than the general measures. Oxygenation, nebulization, all can be done. Yes. You remove the embolus, that is the gold standard management. By catheter, remove the embolus. Or you use the RTPA, that is the tissue plasminogen activator, the component. If it is not available, then you go for the streptokinase or urokinase. Other fibrinolytic agent can be used if these are not available. Very cheap is the streptokinase. Active treatment, other than that, first of all, loading dose can be given, and then heparin should be used, or lower molecular weight heparin. It is about stat dose will be given, first of all, 10,000 to 15,000 units. It should be given directly and then subcutaneously every hourly, unless you see the APTT monitoring that it is about 1.5 to 2 times than control. Or you use the low molecular weight heparin, that is heparinoids, enoxaparin, dalteparin and others. Oral anticoagulants like warfarin sodium, followed by it. Filters can be used in this condition where there is a recurrent type of the pulmonary embolism. Venous filters can be used, or venous ligation, adjuvants, oxygen, antibiotics, rest in the bed, etc. These are the general measures. The streptokinase dose is written is 600,000, same one as we use in the myocardial infarction. And then remaining 100,000 will be given for 72 hours in a drip fashion. Thrombin clotting time should be monitored, and local and systemic fresh blood and the fresh fluid plasma. And ECA, it means that it is the fresh blood given or a fresh fluid plasma because of too wide disseminated intervals for coagulation. To avoid it, you can give these products. Heparin's dose is written, I would say that's 15,000 bolus, and then use 40,000 to 60,000, but 24 hours means 10,000 units. 1,500 units every hourly. Monitor the APTT, infusion pump can be used, and specific antidote. If heparin is used extensively, it is protein sulfate. Heparinoids are written here, enoxaparin 1 milligram per kilogram, about 75 to 80 milligram ampule is available. Subcutaneously, it will be given on the abdomen, 12 hourly first, for 3 to 5 days, and then per day for more than 5 to 10 days. Oral anticoagulants, vitamin K antagonists, like warfarin sodium, dicamerol can be used. So the case presentations was done previously, and the valve score in that case was definitely higher, more than 4. So mortality afterwards is more in that valve score. And the diagnosis can be made by the gold standard methodology. These are my message. In the last way I will say that presentation is important. Secondly, which is available, what investigation available at that time should be done, and call for the CT angiography, which is available in many centers. Direct angiography is only limited to certain specific centers, although it is gold standard. So the management, first of all, diagnostic criteria is clinical examination and investigation. The management is you have to remove, if the catheter based procedure can be done, it should be done. For example, in Karachi NICVT offers it. It's directly the catheterization and removal of the embolectomy. Free of cost. If it is not available, then go for the other measures to dissolve this embolus. You go for the fibrinolytic agent, you go for the anticoagulants, and then you go for the vitamin K antagonists. And then afterwards maintain it with the platelet inhibitors. After the discharge, if there is you go for the platelet inhibitors like, for example, the acetylsalicylic acid and the clopidogrel, etc. But with full exercises, the limb exercises, changing the position frequently, etc., will help to combat it for the prevention. I hope that you have understood this pulmonary thromboembolism. With my discussion, repeated this video 2 to 3 times, go to the text book, and you can remember it very easily. Inshallah, we will discuss some other topic very soon. Assalamu alaikum wa rahmatullahi wa barakatuh.